afternoon and welcome to the CXPA Australia Network Good Friday Appeal event. Before we begin, I'd like to acknowledge the traditional custodians of the land on which we are gathering today and pay my respects to elders past and present and extend that respect to other Aboriginal and Torres Strait Islander people. My name is Anita Ciasios and I'm the founder of the CXPA Melbourne Network. With me today, I have Zora Hall and Rod Netterfield, two of the CXPA Australia Network Committee members. Without further ado, I'd like to welcome our guest speaker, Alison Errey, the Executive Director of the Royal Children's Hospital in Victoria. Good afternoon, Alison.
Good afternoon, Anita. Thanks for the opportunity to be here, and hello, everyone.
Thank you so much, Alison. And I just wanted to actually also thank all our members across Australia that have actually joined, as well as our international CXPA members. Alison, as you know, the Royal Children's Hospital goes back to 1976 for me, so it's a pretty emotional day. But we've had lots of conversations over the last few weeks, and in particular, we've all been talking about the year of 2020, which was a significant year or a milestone year for the Royal Children's Hospital, but also a year that many of us will never forget. I want to go back to the day where the Victorian Premier announced that we will suddenly go into lockdown for Victoria. And can you tell us a little bit around what that was like at the Royal Children's Hospital, what you had to do as a leader, and how you actually started to prepare for the year that was coming ahead?
Yes, well, it was certainly a historic day, not only for the Royal Children's Hospital, but all of Australia, I expect, certainly in Victoria. For us, though, as a healthcare organisation, we had been very closely watching and monitoring the situation in relation to COVID as it emerged overseas. And so to a certain extent, we were kind of waiting for something to happen, but not exactly knowing what. We had, in fact, been meeting almost daily since January and very closely monitoring the situation as it emerged. But I suppose on that day, we then obviously had to very quickly respond, and it responded in a number of ways. And it wasn't just a facilities response. We obviously immediately stood up health checks for visitors and parents and staff coming in. We were here overnight, all of the executive team, moving furniture, removing furniture, putting it in storage, taking down curtains, replacing them with new curtaining that had been approved by Infection Prevention and Control. We stood up staff screening. I suppose the important thing that came in at that time was visitor restrictions. And I think that we were in a particularly unique situation, being a children's hospital, where all of a sudden children couldn't have their household members, their siblings, people that are so integral to the healing and therapeutic response in a care situation for children. And I think that for me, and probably the executive team here, and certainly the clinical staff, that was the one that was probably the hardest to cope with, that all of a sudden the patients in our care couldn't have their little sister or big sister or big brother in to come and visit them. So there were some tough conversations that had to have on the ground floor when people were arriving. This wasn't a decision that was just for the Royal Children's Hospital, of course. These were restrictions that have been put in across Victoria in healthcare settings and certainly in aged care settings. So we had to, I suppose that was the most confronting for us, because we're a hospital that's been built very much around a family environment. The entire hospital has been designed to be a family setting. You can probably see my background here, which is what we call Main Street. Our hospital was designed to actually replicate a community and replicate a house. We have individual patient rooms, and all of those rooms have a space for mum and dad to sleep, for brothers and sisters to play. It's designed as a mini home. So for all of a sudden, for none of that family connection to be allowed in, I think was probably the toughest thing for us, notwithstanding the dealing with the pandemic and the risks, very high risks associated with this very new virus that none of us knew what was the impact of contracting it, what was its transmissibility, what would be the impact on us and patients in our care. But I suppose those restrictions that came in were quite confronting.
Yes, and I think also certainly in your role as being the the head of communications at the hospital, you can never have enough communications. What was that like, Alison? What's pivot strategy did you actually undertake then? I assume you probably didn't have much sleep.
We didn't have a lot of sleep, but there were a couple of things that confronted us, Anita. Very quickly, I suppose we recognised the value and the importance of having a well-informed workforce. Mums and dads and patients were obviously asking questions, and they're asking questions of the nurses and the doctors at the bedside. So we had to make sure that our staff were fully informed, and we undertook a principle, I think, of that we told them probably more than they needed to know, but they heard it before anyone else as well. So we immediately stood up a daily COVID briefing for staff. The other important thing, of course, to allay fears for children, because this is a very confronting time. Like all of the media, everything that children saw on the TV was related to COVID, and quite graphic images and a lot of anxiety. So education for children was really, really important in our response, and we realised that very early. So we produced a range of resources for patient-facing resources and child-facing resources. One, to address their fears about, what really is this pandemic, but also a lot of, I suppose, infection control, education about how they could keep themselves safe. So we did things like, child-facing videos around hand washing, and how to sneeze into your elbow, little things like that. We did produce videos about how to have a COVID swab. Now that, for anyone who's had a COVID swab, that's confronting for an adult, let alone a child. So our video about explaining what's going to happen when you have a COVID swab for children, that's been viewed now more than 900,000 times. So the education, the communication, absolutely was a priority for us, for staff, for patients, for children who may never set foot in this hospital, because we know we've got an enormous online audience. In fact, more people will use our information online than will ever set foot in this hospital. So it was we very quickly stepped up into patient-facing, mum and dad-facing information, clinician-facing and staff-facing information, all of which, particularly as external resources, we made sure were translated into community languages.
Yes, indeed. And I guess we'll talk a little bit about the actual technology that took place, and also about the metrics as well, and the data insights. But before we actually go to that, I'll hand over to Zora, who's going to tell us a little bit about the Good Friday appeal.
Great, thank you, Anita. So really proud to be supporting this cause today, and thank you so much, everyone, for your support. So really, Alison, it seems like it's been very tough for 12 months for the Royal Children's Hospital, just like for everyone else really around the world. But yeah, it's great to hear that it's been some great innovative ways how you really ensure that's just really the minimum impact on the patients and the family's experience. So really today, supporting the Good Friday appeal, which has raised amazing 381 million over the last 90 years. So that's incredible. And really today is the landmark, it's the 90th year. So yeah, significant milestone. This funding has been used for new equipment, staff training, and also the medical research at the hospital. The face of this year's campaign is Malu that you can see on my screen here. Also, you can the story so in our campaign on the website. But really, he's a very gorgeous 2-year-old boy who is now up and running again after a complex complex 12-hour surgery that took place in July 2020. It was to disconnect one half of his brain to minimize the impact of debilitating seizures. So a very complex surgery and rehab afterwards, but yeah, just one of many stories that would not have been possible without the Good Friday bill. So yeah, we thank you for your support, and we do encourage you to donate and appreciate that. So just put a link, donations in the chat as well. And now back to you, Alison. So we heard about the communications that was so critical during the past 12 months. The other component was the technology, of course, that underpins everything and to light. So one of the great innovations that you've done was the expansion of your telehealth service, offering virtual consultations. Can you tell us a little bit more about the transition to the virtual consultations and how it went for both the clinicians and the patients?
Certainly, that was probably one of those things that we did stand up very, very quickly. We run one of probably the busiest outpatient clinics in Australia. And I think I'd mentioned in our previous chats, on any given day, we'd have about 1,500 appointments through here, Monday to Friday. So incredibly, incredibly busy. So within 2 weeks, we transferred 70% of all of our consultations went to telehealth. So as you can appreciate, that was an enormous undertaking. A lot of our staff were already really geared up. They'd been familiar with telehealth, but not to the extent that we obviously had to now transition to. Most importantly, we had patients and families who had never engaged in telehealth. So that was, we needed a lot of education and support for them. Some of the things that we did, we created videos and online training about how to log into your appointment, how to prepare for your appointment. But as this progressed, and what we all hoped probably back in March that we would be over this by in a couple of months, well, obviously that didn't transpire. We're still doing telehealth now. And still more than half of our appointments still have to be telehealth, largely for density limits in the actual clinic rooms. So we created a range of resources for educational resources for families about how to log in. And as this progressed, we knew that there were a lot of procedures that weren't being done. So we then had to start creating videos to actually explain to parents actually how to do some of those basic clinical procedures, safe and appropriate clinical procedures at home. So things as we taught parents how to actually take a sputum sample for our CF patients. We did a video on how, for children with kidney disease, how parents could actually measure their acidity in the urine. So we did urinalysis, and then they would be able to actually feed that back to the clinician. From a clinical point of view, though, and those remote, this is supporting clinicians outside of our hospital. We did a lot of educational videos and clinical practice guidelines for community-based doctors and clinicians in other hospitals, things like how to take a COVID swab in infants, because like we'd already discussed, it's bad enough actually doing that swab in an adult, right at the back of the nose. But trying to teach a doctor how to actually take a COVID swab from a baby was actually something we really needed to do. And again, this is all long distance using technology. Another, probably the most popular educational online resource that we created was for clinicians, which was around distraction techniques, and actually how they could care for babies and children and young people through distraction techniques while they were having to do procedures. I think what we saw, and not just in Melbourne, but certainly around Australia, is we saw the data was showing us that things were not happening because people were scared to attend a hospital. Our emergency department presentations were about a third of what they normally would be. And remembering this went through all of winter. Our winter presentations are around 300 a day. On some days we were seeing about 68, 70 presentations through our emergency department. So what does that tell us? That tells us that mostly, maybe, hopefully, children were not getting sick. But what we also knew, they certainly weren't playing sport and they weren't falling off monkey bars at school. But we were also concerned that people were reluctant to seek treatment because they were scared of attending a hospital. We know that that certainly was the case, that they were scared to attend a GP. Childhood vaccinations just didn't happen during lockdown. So those really important things that keep kids healthy didn't happen. We were using the data to show that. So again, we moved to online education and using technology to encourage parents to continue to seek that healthcare for their children, but also then to skill up the community-based paediatricians and the GPs, and particularly in country locations that would never have had to do those sorts of procedures potentially. So we actually were doing online consultations and also providing online education for those people to actually be able to continue to provide that care during this extended lockdown. You asked me about technology. We stood up new COVID websites, internal and external. We actually created a chatbot. So we were using the data to actually be able to see what the most common questions that people were coming to our website for. So we stood up and created a chatbot to be able to respond to those. We introduced 24/7 responsive digital messaging. So we introduced a number of digital screens around for to be able to relay messages about new exposure sites, and obviously the case definition changed. So new symptoms for people to be looking out for. We obviously did a lot of translated resources. We created virtual CEO updates for our staff, where our CEO basically briefed staff every week on what was happening. We moved to the COVID updates, as I'd said. The important thing is, and this is where the benefit, I think, of the philanthropy and the Good Friday appeal comes in, recognising that children could not have those visits. We actually had already been doing game shows for kids where they could dial in from their hospital bed, and you can see in the bottom right hand corner there a photo of one of our patients dialing into hospital lingo. So we increased our patient game shows from 2 to 5 a week, because they just could not have access to their visitors and their sisters and brothers and their friends. As I've mentioned, our COVID video series, the screening, the COVID staff app, we created an app for staff to be able to do push notifications and send out time critical information and changes to COVID related information, and obviously the staff and visitor screening. Online, what I'm showing you there is what is our digital, I suppose, our ecosystem and our ways of using technology to communicate with people. I've called it a lifespan loyalty because we do provide a range of all of our channels, if you like, and our assets to have something for everyone around the continuum of their lifetime. So we have, I suppose that's what I would call our digital ecosystem, if you like. That gives you an idea of the audience numbers. And when we combined all of that, at any given time, we have I appreciate there'll be some duplication in some of this, but about 11.3 million people across those channels. And basically we saw growth because people were coming to us for that information. We saw growth of between 5 and 25% across those own channels.
Incredible. Really, the growth, and again, the technology was so important to accommodate that high demand, and really links absolutely one of the enablers for the effective communication. Right. Hey, listen, I'll now hand over to my co-host Rod, who's got, I think, a couple of more questions for you. Over to you, Rod.
Definitely. Thank you, Zora. And thank you, Alison, for giving us your time today. So I'll probably just do a quick shout out to all of our attendees today. If you have a question that you're wanting to ask Alison, please just use the Q&A, and I'll give a moment or two for you to put those in so that we can ask Alison some questions that are of interest to you. Look, Alison, probably what's really captured my attention is you seem to have a lot of data points that you're talking about, both at a strategic level and a micro or a tactical level. And I think so often, I think CX professionals struggle to be able to quantify and measure their success. So I'd love to hear a little bit more about, when you talk about measuring, monitoring and reporting success, what does that look like for you at RCH?
Probably like everybody, all of your members, and certainly the data basically drives everything that we do. It is, like I said, a lot of the proactive things that we do for patients here. We're a public hospital, and the government doesn't fund us to do patient game shows. That is genuinely what comes out of the money we get from Good Friday Appeal. All of the videos and everything we do. I have a TV studio in our hospital. I am genuinely blessed, and I have fantastic video producers. But again, that's not funded out of the taxpayers. That is actually funded through philanthropy. So the money that is raised through things like Good Friday Appeal allow us to do that. That would not be happening if we weren't supported so generously by the community. So as a result of that, obviously, I've got to be able to demonstrate the bang for the buck, like all of us, I suppose. So we use we're heavily data driven in my team, and we use it for proactive and reactive. We use it, like I said, we monitor our website as far as what are the questions that what are the most downloaded pages, what are the top hits there, and then we will use that information to probably create content to address that need. If I can give you a bit of an indication, our kids health info fact sheets, I think the last year were downloaded about 8.8 million times globally. So every month we monitor what are the most downloaded kids health info fact sheets, and then we will create content to address that obvious need. So that's how we're using it from a proactive point of view. It's obviously informing a lot of our future work and our workflow. We're looking at, where are the hotspots? Where are the information gaps? Like I said to you, we were very closely monitoring at a national level the childhood vaccinations. And we saw that kids just were not getting their routine vaccinations during COVID. And largely because people were scared to go out of the house and scared to certainly come to a hospital or a GP clinic. So what we did is we used that information to actually stand up a drive-through vaccination clinic in our car park. So children could continue to have their very important childhood vaccinations without leaving the safety of the family car. So that's one way. I mean, that was how it was informing our operational response and certainly informing our communication response. There's a couple of other things, though, that like we've all struggled with. I mean, how do we know the value of, is this creating behavioural change? Is the information that we are creating meaning that kids are in fact healthier? I think it's difficult to draw a long bow to say that because we created social media content to say, keep your vaccinations up and here's a drive-through clinic, that we saw a spike in childhood vaccinations. We certainly could manage the data of what we could see. But I'll give you a great example of something that we created purely from a customer experience point of view. And we were the first Victorian hospital to do this. And we now stream our ED emergency department data straight live to our website. So 24 hours a day, you can actually log on to the RCH website and see how busy our emergency department is. Now, can we actually then track how many people don't show up as a result of that? Clearly not. So what is the data that demonstrates to me that there's a good return on investment there? What we did see is we saw a 75% reduction in the number of calls going through to the ED reception area, because 75% of those calls were ringing up to say, how busy are you and should we come in? The other thing that we actually saw, which was a really good indicator of the success of that, was that we saw a significant downturn in what we call code greys here, which are aggression incidents. Because this was all about their customer experience and creating, allowing people to make informed decisions about whether they'd come to our emergency department. Again, using data, we saw that 60% of the 4s and 5s, which is a triage category, 4 and 5, so the less seriously ill, 60% of the 4s and 5s presenting to our emergency department had driven past their local hospital to come to us. We appreciate we've got a very good brand and reputation, but it's not unusual for some families to drive 2 hours to bring their child to the Royal Children's Hospital. Now, those 4s and 5s also, unfortunately, happen to have the longest waits. So we wanted to create something online using technology that actually allowed people to make an informed decision about whether they're actually going to come in and spend that time. Now, one that was around customer experience, but also around managing expectations. So if they saw that we were really busy and it was likely to be a 6-hour wait, at least they knew that before they came in and their expectations were realistic. What was happening otherwise is that they were showing up and having a 6-hour wait and obviously becoming very distressed. And that was causing distress for them, distress for the child, and obviously some aggression incidents. So yeah, you've got to be a little bit innovative in what sort of data you're going to use to actually monitor the value of what you're doing. But like I said, could I tell you how many people hadn't come in as a result of seeing that? No, because you don't know what you don't know. So we actually look at the data to see what other sort of benefit. From a social media point of view, we are very obviously we are the most followed hospital in Australia. We probably have one of the largest followings of many organisations, and we are very heavily data driven there as well. I know that I have a very loyal and active, easily activated social community that when we will do a post to say that our emergency department is experiencing high volumes of children, you might have extended delays, routinely we'll get a reach there in excess of about 200,000. Often with about, I think the last one we had about 389 comments on top of the reach. So that shows me engagement as well as reach. So like I said, our data informs everything we do. We monitor it every day. We look at where the hotspots are, where the issues are, how we can proactively step into that space to address that community or customer need. And also then what we need to do to react to it from an operational point of view. Sorry, that was a very long answer.
That's all good. It was brilliant. It was brilliant. I've taken a lot of notes there. So yeah, thank you. I think there's some pieces in there for everyone. Probably got, I think, time probably here for one question. I think that's coming in around, Australia is a beautiful, diverse place, and so sometimes we can create a proposition or an offering, but sometimes we might miss what's the need or the want of a minority community, a disadvantaged group, or whatever it might be. And I think earlier you might have spoken about doing some things in multiple languages, if I understood you right. So, I'd love if you have anything further about, how can you tap and make sure you understand the needs of, smaller segments, let's say, within your customer communities, and then how you can build propositions for them.
Yes, look, I think that's a challenge. Not for a second am I going to pretend that we do it enormously well. We don't, and there is a lot of improvement that we could do. I would also say, though, that I think that the Victorian government recognised very quickly that they had not addressed the needs of culturally and linguistically diverse communities. That remains a major gap. What we did, we tracked, we were the first paediatric hospital to have an electronic medical record. So we were able to actually look at our data from our current patients and outpatients, the children attending specialist clinics, for their first language. So we actually extrapolated that data and understood what is the language need of the people who are our current families. So we have a very good working relationship with SDS. And so we actually use them to translate and subtitle our COVID-related resources. The gap, though, there is that, as I said, the bulk of families accessing our information are not our patient base. They're, in fact, out there in not only the Victorian community, but in fact globally. I can see a heat map at any time of the day about where people are actually accessing our information. So what we did is we actually cross-referenced what are the top 10 languages of our patient base and what are the top 10 community languages on Victoria and, in fact, Australia. And then we actually did a matrix there and created translated resources for those communities. Now, I am very pleased to say that our translated resources have been taken up quite well, particularly in the COVID space, which again indicates that there was a genuine need there. But we were very careful not to replicate what the government was already doing, so ours was very much child-facing. We left the adult communication to the government and then stepped in to do, putting the patient, our child, at the centre of everything we do. So, look, there's still some work to be done there, Rod. And, we learnt a lot through COVID. We need to now leverage what we learnt to continue that patient experience, consumer experience outside of a pandemic situation.
Fantastic, thank you. And what I loved in your response there, so often with organizations I work with, they think they have to do it all themselves. And so what I loved in that is that you're using your partners. So it was obviously the government, but also even when you mentioned there, you know, tapping into SBS and working with the partners and the ecosystem around you. Sorry.
Yeah, no, I look, and wouldn't it be good for all of us if there was more of that? In fact, I mean, how many times do we see organisations, you know, duplication of effort and money and time? And if you just go looking for it, sometimes there's some really good partners and resources already there. And like I said, certainly I would say at the Victorian government level, increasingly as we moved through the pandemic, they started to recognise the value of that even more.
Yeah, fantastic. I think Anita's popped back up on screen, so I think she's going to do a quick fundraising update for us on how we're going.
Yeah, that's right. Thank you so much, Rod. So Alison, I'm going to have a question for you relating around your connections from an international perspective. Obviously, the certain countries were in a far more serious situation than what we were, but I'll let you think about that. In the meantime, I did actually want to show my screen. I did want to thank some of our members again who have joined us today and have very kindly donated. Thank you so much to Ian Stockwell and Rod and Zora, of course, and Craig Kenner and Bill Sullivan and Anna and Peter Siasius and Managing CX who have very kindly donated. But Alison, so let's just talk about from an international perspective, you know, what is it, what was happening with regards to, you know, the experts, talking to the experts overseas? Were you reaching out to them? What was happening with regards to that?
So the interesting thing is about, obviously this COVID impacted international communities far earlier than it impacted Australia, and a lot of that was seasonal. And I think I'm not a clinician, I'm not pretending to be a clinician, but certainly we were heavily involved in interpreting that clinical information. So we had a lot of connection with counterparts overseas. Our chief of medicine, our chief nurse, we reached out routinely to find out what's the experience over there. Most importantly, what the research was showing us, and very quickly what emerged over there was that children weren't necessarily being so heavily impacted medically, clinically, in a physical disposition from COVID. However, what we learned is that they were incredible super shedders. So they were absolute transmitters. So learning from our overseas counterparts and what they were experiencing and what they were learning over there allowed us to actually respond accordingly. And that is what helped inform a lot of the decision making about school closures. As much, like I said, children weren't getting sick, but they were absolute little virus balls, and they were really, they were spreaders without actually being sick. So a lot of the community decision making around restrictions was based on what we learned, what we were learning from our counterparts overseas. So equally, from our point of view, from a communication point of view, like I said, we have a global heat map of who's hitting on our website and who's downloading our resources. And I can tell you that the bulk of the resources now, our downloads are coming from the US, the United Kingdom and India.
Wow,
so,
that is interesting. That is really interesting, actually, and I'd love to be able to see a view of that, you know, dashboard that you're referring to. But Alison, I'm actually also thinking about just talking to a lot of the practitioners. Everyone's reflecting and going back and reviewing their strategies. Everyone is spending a lot of time looking at all their risk management plans. Is that something that, you know, I'm assuming something that the hospital is doing, and if so, what does that look like at the moment?
Yeah, interesting enough, but very timely, because we've actually just done a board risk workshop on Monday, where we're actually refining not only our risk appetite, but what are our key organisational risks. And because obviously no one necessarily, we absolutely had pandemic preparedness plans. That is just what we do. But what did we learn? So preparing for the risk, our biggest risk, actually, like I said, knowing what we did, that it wasn't necessarily patient load that we were going to be dealing with, it was actually risk to our workforce. Right. That we actually would lose workforce as a result of the adult workforce either being exposed to COVID, contracting COVID, or being furloughed as a result of potential exposure, which meant that we actually couldn't run the hospital. So that actually became our biggest risk. Workforce sustainability remains our biggest risk now,
Yes.
even though we're hopefully out of the worst of the pandemic. So we have had to absolutely adjust our risk profile in relation to that as a result of that. And that's, like I said, workforce sustainability has now become one of our highest risks.
Yeah, and you may be able to share or not, but what's some of the mitigations that you think you might actually put in place moving forward?
Well, this is the challenge that we're now facing. At the beginning, we split teams, Anita, so that whole teams wouldn't be taken out, if you like, that terminology, by either potential exposure to COVID. So we are still operating a split team model. That's having impact on our service delivery. We've obviously had to reduce elective surgery. This is across all hospitals, by the way. So because we can't afford to have, if we have a team of 4 urologists, for example, and we've only ever been allowed to have 2 on at the time, because you can't have them all on site at the same time, that if there's an exposure, they're all furloughed and obviously can't operate. So we've had a split workforce. That is one of the risk mitigation strategies. We're now seeing enormous levels of RSV, respiratory illness,
Yes.
like a lot of hospitals. We are seeing unseasonably high presentations with respiratory illness, which is meaning that when I was saying to you, our ED in winter would see about 300 patients. In February, we have averaged 348 patients every day for February. So that's impacting our workforce sustainability and emergency department. High levels of sick leave, high levels of fatigue, and we're now needing to actually adjust our staffing to be able to and that's just in the ED. I'll give you an example also of in our support services, who are our cleaners. Because of the need for increased infection prevention and control activity around the hospital, the number of infectious cleans, what we would call, has tripled, not surprisingly, which takes much longer. So we're actually needing to recruit more cleaners. And when we can't recruit, we're having to onboard casuals, which is actually then impacting on the time it takes to induct people appropriately.
Yes.
So there's lots of flow-on effects that are happening. And like I said, workforce is actually now our biggest challenge.
Thank you so much, Alison. And that's sort of really highlighting a lot of, things in my mind around how do you, with the sick leave, etc. There's a lot of organisations that are going through that, but also around the behavioural changes in that people no longer want to go in public transport to work anymore. They want to continue to work from home. And so that's just uplifting the technology requirements as well for organisation. But I will ask Rod and Zora to come back onto the screen, if that's okay, before we actually finish off. And I don't know whether, Rod, you've got any other questions, or Zora at all?
No, I think you've covered it off nicely there about where to sort of for the coming year, and some of the challenges you're currently facing, which is picking up the bulk of the questions. So yeah, look, I've taken away a couple of really good practical insights and actionable insights from you today. So thank you for sharing. Yeah.
Yes, indeed. Now, Alison, I will make the most of the last few precious minutes that we have with you. As you're one of the key leaders of the Royal Children's Hospital, being the Executive Director of Communications. And my question to you is, what's one of the things that you can share with us that you've personally learned yourself in this last year?
Wow, we've learned so much. I've learned so much. I have spent my entire career, in all truthfulness, in issues management. And always, I suppose, a large external focus, reputation and brand, and external communication. I think what I have learnt this year from this is the value of investing in internal communication. We've completely shifted our focus as far as where we direct our resources. Like I said, we did a lot for external, but I think the telling factor for me, the one thing that I've learned, is the effort that we put in to communicating with our staff from the outset allowed them to feel safe, gave them reassurance that their executive were on top of this and we would get through it. And that's been borne out in every pulse survey that we have done, the People Matter survey. Overwhelmingly, communication and trust in the executive has been the highest rated KPI. And that's because we invested in we actually focused less about our brand and reputation externally and more about keeping our staff informed.
Indeed. And that really just highlights the importance around that employee experience. And, you know, I love how the executives are, you know, really getting down to, and I think probably we've probably all really got to know a lot of people a lot more than what we would have in the past as a result of our interactions that we had, or additional effort that we had to undertake to be able to get things done and deliver to those objectives that we had actually all set. Alison, I cannot thank you enough. You've been very, very generous with all of your time, the visit that Zora and I made to the hospital, the rehearsals that we've had with you, and certainly the opportunity for us to get more insights and learn a lot more about what goes on in the background of the Royal Children's Hospital. And we're very, very grateful for your time, and very grateful to all our community members that have joined us today from Australia and from overseas. And we hope that we can reach our goal of $1,000 by the end of next Friday, which is actually the Good Friday Appeal Day. We're halfway there, nearly the $500 mark. So we would be grateful for any other donations in the next week or so. Thank you again, Alison, and thank you to Rod and Zora. Have a good afternoon, everybody. Bye-bye.
Bye.